So I'm going to be talking today about two things. One is the realities facing diverse older adults and some of the challenges they're facing, and also how we can think about in an interdisciplinary way how to support older adults who are people of color. The second is that the work that I do is really focused on the direct care workforce, and I'll offer some definitions in a second. And they are critical also to the lives and the supports of older people of color. How do we transform this sector? I'll end this presentation, my 45 minutes, looking at some recommendations and a pathway forward. By way of introduction, my name is Robert Espinosa, and I work for an organization called PHI. For a long time, we went by our longer name, which was the Paraprofessional Healthcare Institute. But as you all know, terminology becomes outdated, and paraprofessional isn't really a term that's used anymore. What we do is we do three things. One is we study and analyze public policies that shape direct care workers and the broader aging and long-term care sector. And we produce data and new studies and a wide range of reports and analyses. We, we also have a variety of workforce innovations and consulting service lines where we work closely with nursing homes, with home care agencies, with various residential care settings in areas such as training, advanced roles, and recruitment and retention. And so we work closely with these providers to help them figure out how do you strengthen and optimize these workers, and how do you provide better supports in the home, in nursing homes, and in various settings. And then finally, we advocate at the federal, state, and local level for policy reforms that can strengthen this workforce. We often say that we have a 360-degree perspective on this workforce and this sector. We bring our analysis and our data, our experience really through original research, through what we call a provider learning lab, where we're learning in the field through interventions, in rural settings and in urban settings, and also through a variety of relationships we have in New York City with workers and with disability service advocates that really help us understand how do we change this sector in all parts of the country. So that's our wisdom. The philosophy of our work is that when we believe that caring, committed relationships between direct care workers and their clients are at the heart of quality care. And those relationships work best when direct care workers receive high quality training, living wages, and respect for the central role they play. I should also add here that prior to PHI, my experience was in both the racial justice field and also the LGBT rights sector. And so I'll be drawing from that experience to talking about kind of the issues facing diverse older adults. So the first part of this presentation is focused on thinking about diverse elders. Who are they, and what are some of the challenges facing kind of this very diverse and broad demographic? One thing to know is that we are living in a time in which our country is becoming increasingly older and increasingly more diverse. So one of the stats that we often put out is this reality that the population of this country is just becoming increasingly older. And what we're seeing is that the number of people aged 65 and older in the US will nearly double between 2016 and 2060, from about 49 million to about 94.7 million. This is a rapid aging of America that, of course, has enormous implications for our country, for policymakers, for industry leaders, for people working in health and social services, university thinkers, a wide range of thought leaders, right? What does it mean for us to become an increasingly older country? Within that, we're also becoming more racially and ethnically diverse. And here I point out that the proportion of older adults of color will increase from 23 to 45% in that period. And the proportion of older adults who are immigrants will increase from 14% to 23%. In many states, by the way, this is already the case, like California, New Jersey, states where we have higher percentages of people of color. But as a country as a whole, it is important to note that we're becoming more diverse. Finally, there isn't as much data on LGBT older adults, but for researchers who study that sector, what they point out is a population of LGBT older adults 50 and older will increase from 3 million right now to about 7 million in 2030. So we're just seeing a wave of more diverse older adults. Central to this conversation and understanding the realities of LGBT older adults, and oops, I think sorry, didn't mean to change that, is just a few dynamics, right? One is the realities of what the field describes as the social determinants of health. Um, this is this is an important framework because it governs how many policymakers think about how racism, how sexism, how homophobia, among others, are shaping the health outcomes of people of color, of LGBT people, and so on. Social determinants of health really speaks to the variety of environmental, social, and economic conditions that are shaping our health, both our healthcare access and also just our health outcomes. And there is kind of a broad range of variables that are often included in that description. I mean, they include things like environmental conditions, they include things like economic access to healthcare. Um, Bias and discrimination is another example. I think that shapes how our health is determined across the lifespan. The second piece that comes out in this definition is the experiences of discrimination and bias, differential treatment in employment and education, in housing, with medical providers, and just bias, oftentimes implicit bias. So just being treated differently in ways that the person who is treating people differently doesn't even realize because it's so embedded in how they behave, right? For older people of color and LGBT older adults, what's important here to note is that this experience of discrimination and bias is something that occurs across the lifespan, as early at birth, right? Many people of color are born into communities, into zip codes that dictate their health and life outcomes throughout their entire lives. So how do we think about that lifelong experience of discrimination? Economic resources relate to issues such as poverty, issues such as the communities in which you're born into, how resourced they are economically, and how all of that can shape your access to health and healthcare in general. During COVID-19, one of the statistics that has come out are that nursing homes that are primarily Black or Latinx are just facing higher numbers of cases and higher numbers of death than nursing homes that are primarily white. And one of the explanations here is that oftentimes, communities of color have resources like schools and nursing homes and others that are simply chronically underfunded and lead to poor health outcomes. And that's one explanation for why we're seeing those kinds of disparities. The other piece is segregated residential neighborhoods. Oftentimes people of color are concentrated in neighborhoods that are segregated from other neighborhoods, but in addition to that are chronically underfunded, have lesser political and economic capital, and see worse outcomes over time. And I think many people probably on the call can speak to how neighborhood or place can often dictate health outcomes across the entire lifespan. Other people have written about sort of the role of both legal discrimination and also just everyday discrimination, discrimination that doesn't necessarily get codified in law or isn't as obvious or as explicit, but nevertheless plays out across our lives. We see this, for example, in racial segregation in schools, community, and the workforce. On the latter, people of color are often concentrated into low-wage jobs that simply have fewer protections. We saw this during COVID-19, where many workers of color were more exposed to the virus and were more often part of the essential workforce. But oftentimes they also had lower compensation and had lower protection, less access to PPE or to supplies, to paid leave if they got sick. We saw this with direct care workers, and I'll talk about this later on in the presentation. But what this means is that this leads to poor health outcomes and poor life outcomes as well. Limited access to higher education, so people who study kind of the educational trajectory of people will note that the higher we get into post-secondary education, PhDs, law degrees, etc., the fewer people of color that we see in most categories, right? I think people will point out differences as well. But for the most part, many people of color don't have as much access to higher education. And the opposite is also true, that oftentimes people of color are more concentrated kind of in in the lower levels of education, less likely, for example, to have a high school degree is one example. Finally, we see the role of social stigma and prejudice. Here, the LGBT angle is really important. When you think about, for example, what an LGBT older person who's in his 80s has lived through, or what she has lived through, what you know is that they've gone through decades of just changing attitudes and discrimination, right? They saw their sexuality deemed a mental illness. They were stigmatized for many decades, the 40s, 50s, 60s, and 70s. And really only until about in the last 10 years saw kind of the cultural tide shift in a way that granted them access to marriage equality, most recently to employment non-discrimination, but in many ways are still experiencing kind of the effects of all those decades of stigma and prejudice. And for transgender people, that stigma and prejudice is still embedded in the law and in everyday life. What all of this means for older adults is that that lifetime of discrimination accumulates and it amplifies in older age. So they enter settings like nursing homes and home care and private homes, but also assisted living facilities, only to encounter that discrimination again. So what does it mean that that discrimination is still happening in those areas? It's important when we think about racial and LGBT discrimination to also talk about the overlay of economic vulnerability. We see higher poverty rates for the most part across categories of people of color, and we definitely see it among LGBT older adults. Oftentimes what this means is that throughout their lives, they've been discriminated against in employment or relegated to positions that didn't allow them the savings potential or the potential to build assets. So when they're older, they just have fewer supports as older people. I'll talk about this later, but in many ways, when you're older and you need kind of formal daily support, paid daily support, unless you've saved enough, what you really need to do is spend down your income and assets to qualify for nursing home support or Medicaid support. And what that means for many people of color is that whole lives, because they weren't given the same opportunities to build their assets and incomes, nursing homes really become the only option. Diminished retirement supports, I mentioned this, and for a variety of reasons, people work in jobs where that simply isn't the opportunity. I know that from my parents, but probably for many people on the call as well. A worsening wealth gap. So the wealth gap between white and Black Americans, for example, I think is about 10 times as wide as within other communities. And so it means that, especially Black people, but also other communities of color, simply weren't offered the opportunity to build their wealth in the same way. And we see this with direct care jobs, which is my professional focus. Oftentimes people of color are concentrated in jobs with low wages and few retirement opportunities. And that shows up in later life. I said this earlier, but there's ample research showing higher rates of numerous chronic diseases, including diabetes, hypertension, Alzheimer's, and other dementia, HIV and AIDS, et cetera, among people of color. Of course, those differences vary by population within that, and higher mortality. In short, people of color and or older age living worse off and living shorter lives for the most part. We also see limited access to health coverage, although Medicare does cover quite a few people, in their mid to late 60s and beyond. We do see that the treatment within healthcare settings is just often poorer in quality. We see, for example, many Black people report that their pain is not is taken as seriously by doctors, for example, as other people. And what this means is that they're forced really to live with chronic pain and not be taken as seriously for medications or for other kinds of interventions. And that's obviously a disastrous outcome for many older adults. We also see increased social isolation and loneliness among both older people of color and LGBT older adults. Earlier this year, the National Academies of Sciences, Engineering, and Medicine, which is the scientific body for the federal government, released a path-breaking report on social isolation and loneliness among older adults. I was part of the expert committee that helped advise it, and it's available on their website. But what it shows really is that this is a profound epidemic, and that both loneliness and social isolation kills older people and should be treated as much of a serious medical concern as we would treat diabetes or heart disease as other examples. We also know from this report and from other research that there is a racial disparity and a sexual and gender disparity as well. And so that older people of color and LGBT older adults face heightened levels of isolation and loneliness. The challenge here is that they are less likely to be studied and less likely to be included in evaluations of intervention. So the evidence base on this is also smaller. So that's kind of an added effect of that. We know from other research also that LGBT people are more likely to be single than their peers, to live alone, and they have fewer family support. So they enter older age with just a different level of support from their families, so to speak, and are often forced to rely on friends in their communities, on neighbors, or on paid support. But as I'll show later, that paid support is also strained. And then another frame that I want to talk about is cultural and linguistic barriers. What we know, for example, is that many of the resources that are offered in healthcare settings or in long-term care settings are simply not available in multiple languages. So this affects, a wide range of immigrants or people who have limited English proficiency. And people are treated differently. People of color are treated differently. I mentioned earlier, their pain is not taken as seriously by doctors and other healthcare professionals. My mother is in a nursing home, for example, in northern Colorado, and she doesn't speak English. And she's often told me about instances in which she shares kind of what she needs or what she wants, and her workers or her professionals who help her. It's clear to her that they don't understand what she's saying, but they also don't seek other people to help translate her. And oftentimes there aren't other people in the facility to help her translate. So what it means is that they just don't receive kind of cultural and linguistic support. We also know that LGBT people face quite a bit of discrimination and bias and hostility in nursing homes and in residential care settings. Bias, discrimination, oftentimes violence as well. And so it's important for us to think about how all those barriers are playing out. Finally, I work in the advocacy infrastructure, which is the structure where we are advocating for public policy reforms and government interventions at the federal level and at the state and local level. And my experience has been that there isn't a lot of dedicated infrastructure for any of these issues. The national people of color aging organizations that exist, which I'll describe in a second, tend to be service oriented, and they tend to focus more on delivering services and advocating for that, but less for policy improvements and how the law should change, so how we should systemically address all of this. I often see a lack of racial and ethnic diversity among executive level positions with presidents and vice presidents among my peers, which of course then shapes to what extent their organizations are advocating for any of this. And I don't see a lot of aging focused organizations who are explicit in their racial justice approach. So many of them talk about disparities, and of course we'll talk about diversity, but they don't look at the root causes of these problems or what are the kinds of solutions that could really change the conditions for older people of color and LGBT older adults. What this means is that we are focused more in a sense on looking at services that people need, not the root causes, and that's a major problem for us as an infrastructure. So the next part of my presentation is looking at the emergence of a coalition in 2010 that really sought to address what I just described, which is the lack of advocacy infrastructure. I was part of this coalition's emergence. I was part of the co-founding. So I'll be speaking a lot from my personal experience, but also a lot of this material is available online on their website and in another number of areas. So in 2010, I was working for an organization called SAGE, and we were part of a coalition of 7 national organizations that came together to really address a hole in the advocacy infrastructure at the national level. What we saw is that there wasn't enough attention in Washington, D.C. on the policy issues facing older people of color and LGBT older people. And so we came together. These were the 7 organizations that are represented here on the side. There were about 15 people, 7 organizations, and we came to just talk about what was our history, what were some of the issues that we were seeing in our communities, and what were some of the things that we wanted to advocate for at the federal and national level. We realized early on that there were 2 purposes for this coalition. One was to push for policy improvements at the federal level and to look at all the ways in which that could happen. And the second was to educate within our own communities around the country about these issues and to really build that grassroots that could help push for these policy reforms. And those became the guiding purposes of the coalition. The three areas where we saw opportunities for policy reform was one, in regard to the reauthorization of the Older Americans Act. For those of you who aren't familiar with federal law, this is the largest funding vehicle at the federal level for older Americans. It funds what people refer to as the aging network. These are area agencies on aging, state units on aging, and tribal units on aging that provide services to older people all around the country. If you're in any zip code in this country, you can find your area or your state or tribal unit on aging, and they're kind of a one-stop shop where you can look for resources, etc. Many of them are severely underfunded, but it is the primary way in which the federal government allocates funding to what is called the Aging Network. Every 3 or 5 years, the Older Americans Act comes up for reauthorization, where people come together and talk about what needs to be changed, what can be improved, and what can be included. And what our coalition recognized is that there was an upcoming reauthorization at the time where we had an opportunity to include a number of measures that would have dramatically improved supports for both older people of color and LGBT older people. Social Security at the time, and still, is always under severe attack. People think that it's a program that will quickly kind of run out of money, and that it's also, we need to think about other market-based approaches to providing economic support for older adults. And we disagree. We felt that Social Security is a program that should be preserved, and it should be bolstered and made more equitable to our communities. So we outlined that as a policy goal. And then finally, many of you remember the Affordable Care Act became law in 2010. And in the years afterward, there was an opportunity to really make sure that it was implemented in all the ways in which the original legislation kind of had outlined. And so we saw an opportunity to both educate our communities, but also inform the implementation of the Affordable Care Act. This is a visual of the kinds of principles and emerging themes that our coalition developed at the time. I'm not sure how well you can see these, but I'll just cover a few of them. One is kind of really the principle that aging affects every American, and that we should not be thinking about this as in us and them, but really as where are we in that spectrum and where are our loved ones in the aging spectrum. The second was the idea that social conditions influence how we age. These are the social determinants of health that I mentioned earlier. And we talk here about kind of the role of prejudice and discrimination, institutional neglect, a lack of adequate resources, and a wide range of inequities. We wanted to make sure that we didn't victimize or pathologize our communities. So we also talk about the importance that hardship comes resilience, it comes with agency, and it comes with just ways in which we can really kind of inform all of these debates. Central to all of this was fairness, good health, and financial security. And there are communities unite us, that we were looking more at the ways in which all of our 7 organizations were unified, and not in the ways that we were divided, which is something that we think kind of the way the political right often does. They divide us and kind of pit us against each other. We really believe in multiple strategies, so services, policy, training, and much more. And there were multiple opportunities for reform, and that all of this was kind of under this model of shared prosperity. Anything that supported us ultimately improves all of us. For example, if we're promoting cultural competence within a nursing home, it isn't just the people of color or LGBT people who live there who are supported. It's the workforce. It's this whole idea that when we learn about one of us, we really benefit all of us, right? And then finally, of course, the idea that united we are more powerful. So this is just a photo still of that initial founding document that guided our work. We quickly, as a coalition, branded. So this is the logo and visual branding that we developed. I was in charge of the branding. I worked with a graphic design firm here in the area to help develop this. You'll see that the colors and the images, etc., really conveyed a quilt and kind of a variety of fabrics and could have overlap our communities, and that was really important for us. Also a circle and the ways in which all of us are connected, but also the ways in which all of us are unique as well. And this is a still of the website that exists right now. And you can see the use of real life images and some of the strategies that exist. But the website is at diverseelders.org. and the coalition is still very active. These were the first two publications that we released in 2010 and 2012. The first publication we released was an analysis around economic security and all the economic challenges that our elders were facing. It was called Securing Our Future. And it was really a landmark report. It was the first time that we had unified all of these issues and we're focusing the attention in DC, in Washington, DC, on the commonalities of these economic challenges. The second report was funded by a grant maker who was interested in HIV and aging. And so we issued a brief on policy recommendations for improving HIV and aging among older adults of color and LGBT older adults. When you look at the data, the disparity data in HIV and aging, those populations are what comes up, largely Black and Latinx older adults and also LGBT older adults. And it's important to know that this is the first generation that we've ever had of out LGBT older adults with HIV. So there's a lot of learning that we have to do as a sector, and we put forth a variety of recommendations in that regard. We had right away some early successes. In September 2012, Senator Bennett from Colorado introduced the Improving Services and Activities for Diverse Elders Act, and it was a bill that would have, if it would have been enacted, basically implemented all of our recommendations around the Older Americans Act. Unfortunately, it wasn't enacted, and that's unfortunate, but most bills also are not, right? I think there are quite a few bills that are introduced every year, and I think upwards of like 95, 96% never make it into law. So we were in that category, but nevertheless, it was a big first step for us to find a senator who was willing to introduce our work. 8 of the recommendations that we were putting forth were included in the Leadership Council of Aging Organizations consensus document for OAA reauthorization. So Leadership Council of Aging Organizations, or LCAO, is a national body of about 75 aging organizations that every consensus year put together a document about what they agree on. And they had never agreed on recommendations that were in support at this level of older adults of color, LGBT older adults. So we really approached all these 75 organizations and said, now is the time and this is the year. And in the final document, they included 8 recommendations. The importance of this is once it's included in that document, that becomes the document that is shopped around in DC and in Congress as the official recommendation of the national aging field. So that was a big first step. And then I just saw kind of a growing brand recognition, so to speak, of who our coalition was, and an increased visibility of issues in the sector, growing media coverage, a lot of attention that continues to this day. The coalition still exists. In fact, it has more staff members today than it did when I started, and they've received numerous private grants to do quite a bit of work. Their current priorities are in integrating elders of color and LGBT elders into health reform, preserving and strengthening Social Security, expanding Medicaid nationwide. This is a program that's always under attack. Strengthening supports and services for older adults living with HIV. The OAA is always under reauthorization, so making sure that that continues. Supporting inclusive immigration reform. We live in a country that's become increasingly anti-immigrant in the last few years, and how do we support that? How do we attack that and support immigrants? And then of course, advancing economic security for diverse elders. So the third part of my presentation is focused more on the work that I currently do at PHI. Direct care workers are by definition, home care workers, residential care aides, and nursing assistants who support older adults and people with disabilities in a wide range of settings. They work in private homes, they work in nursing homes, and they work in residential care settings. We just released our new research, our new annual research on this workforce, and we estimate that there are about 4.6 million of these workers. In fact, this year, for the first time, this workforce is larger than any single occupation in the country. So it's a rapidly growing workforce. They also are a workforce that's really critical to older adults of color and LGBT older people, especially people who don't have family support and people who are more severely isolated. So I think it's really relevant for this conversation around older people of color. They are in many ways considered the paid frontline of support for older adults and people with disabilities. And they often support family caregivers who are working or who need respite and the kind of support that they're offering. Unfortunately, it's a workforce that also experiences high turnover, and I'll talk about some of the reasons for that. And because of that, we estimate that between 2018 and 2028, there will be about 8.2 million job openings in direct care that will need to be filled. That is a major number, and it's a major crisis, because if we do not fill these job openings, it means that any one of us who needs that support at home may not have that support. So how do we think about providing supports that can do that? I think it's a big question for us. Who are these workers? The vast majority are women. About 59% are people of color. 27% are immigrant, and the median age is about 43. That said, our research also shows that about 1 in 4 direct care workers is aged 55 and older. So the workforce itself is also becoming older. There are 4 trends in general that are igniting demand, that 8.2 million number that I just mentioned. The first is that we have more older people, increased longevity, so to speak, right? I mentioned earlier on that between 2015 and 2050, the number of people aged 65 and older will more than double from 47.8 million to 88 million. It's the aging of America, if you read the news, right? Also, with increased older age, older age often brings about increased functional limitations and daily support needs. So we're seeing also higher incidences of people with disabilities. And how do we think about creating supports that support us to live with independence in our own homes, right? By and far, most people prefer to age in their homes and in their communities, as opposed to a residential settings or to a nursing home. And that trend is also driving more money and more people into home care for the most part. And we're living in a time in which we see new family norms. It's more common for children to leave the home. We see more single people and more people without children, and just a cultural acceptance for seeking paid support. We're often asked, how does kind of the long-term care sector differ from other parts of the country? And this is a major way in which we are different than many parts of the world. Other parts of the world, is that, in many other countries around the world, it's not common for children not to support their parents, and seeking paid support is often, not seen with the best of intentions, right? A major reason why workers leave the sector, high turnover rate, is low wages, low compensation. The median wage for US direct care workers is about $12.80. This wage has really only increased by about 90 cents in the last 10 years, adjusted for inflation. So it's virtually stagnant. Because many workers are relegated to part-time work by their employers or by the economy, about 31%, median personal earnings are about 20,000. And if anyone has ever lived or done the math on what a wage of $12 an hour gives you, it quickly gets eaten up by all your expenses, right? And it makes it impossible to really save for retirement and to live a life beyond basic needs, especially if you have children or a major medical crisis. Because of this, about 45% of direct care workers live in or near poverty. This is a devastating percentage of workers. Oftentimes, the training landscape for direct care workers doesn't really equip them for the kind of care that all of us need. Training standards for this workforce is really insufficient, especially for personal care aides who don't do the clinical work that home health aides and nursing assistants do in nursing homes, or for direct support professionals who support people with intellectual and developmental disabilities, right? At the federal level, home health aides and nursing assistants must undergo at least 75 hours of training, and many states go beyond this. But for personal care aides, no state goes beyond 40 hours, and really a lot of states do about 5 to 7 hours. And that means that a lot of times, depending on where you live, you hire a personal care worker. They may not be trained in what you need, right? We're seeing a lack of specialty training on topics like Alzheimer's and dementia, heart disease, diabetes, HIV and aging, etc., or special populations, immigrants, Chinese Americans, LGBT competence, etc., which means that if we have those needs, the likelihood that we'll find a worker who's trained in that is just very slim. Most training programs use didactic methods, like what I'm using right now, which doesn't really account for the adult learners or learning styles that people often need to really acquire those kinds of skills, right? We know that people often need experiential training, experiential methods, or methods that are just simply more interactive and talking at somebody. That doesn't quite work in the direct care context. And it makes it hard, a college approach, for example, for direct care workers. Finally, we see few opportunities for advancement for these workers. It means that most workers really see this as a paycheck and not an opportunity where they can advance in their careers, take on a more optimized role, or make more money. And this makes it hard to stay in the sector. There isn't a lot of good data on direct care workers in terms of turnover or vacancy rates. So it's hard to know like how often are these workers turning over and leaving. That said, our experience in the field is that it tends to hover around 60% or higher. And then when you ask workers the top two reasons why they leave their jobs, they'll often say low wages or poor supervisors. By the way, that's a trend that exists in other sectors as well. Many of us leave our bosses, we don't leave our jobs, right? But that's especially true with direct care workers. And in a time where the economy is better and workers have more option, which is what we saw over the last 5 years, workers often are leaving for other industries like retail or fast food that can offer modestly higher pay or just better benefits. And you can see this in the advertising for fast food companies, for example, or retail industry. We're curious, of course, now that COVID-19 has compelled a recession for the most part, whether or not that will increase. But that makes it hard for long-term care employers to fill jobs. The problem in terms of workforce retention and recruitment is much worse in rural America. These are two charts that we created for an analysis that we did a few years ago in Minnesota. And what you see is that the blue line represents people aged 65 and older, the consumers, so to speak, right? And the orange line represents working age women, 20 to 64, which is the typical demographic for direct care workers. What you see is that in urban Minnesota or non-rural Minnesota, that the demand begins to kind of outpace the supply roughly in like 2034, 2033, right? In rural Minnesota, that demand, the demand starts outpacing them much sooner in the next few years, which means if you're an older person living in rural Minnesota and you need support in the next few years, it's going to become it's going to be dramatically much more difficult for you to find a worker. And that sector needs to think about what does that mean. So I think rural America has always struggled more, I think, with those challenges. All of these challenges are under this kind of an overarching challenge of inadequate public funding and reimbursement. Medicaid is the primary payer for long-term care in the sector. And what we know is that Medicaid budgets are often strained at the state level. It's also highly politicized, and conservatives tend to argue against Medicaid and really limit funding. I think their overarching goal is to eliminate Medicaid, of course, in the long term. What this means is that, for the most part, the only people who qualify for Medicaid are poor and low-income people. And if you're a middle-income person who needs support, you often need to spend down your income or your assets before you qualify for government support, right? It's also difficult for any of us to know how much money will we need for long-term care when we're older, because we just don't know what our health needs are. At age 40, like we don't know what our needs will be at age 60, 70, 80, because we won't know what our health is, right? And many state Medicaid budgets are strapped. There is often little funding to improve jobs. And what providers like nursing homes and home care agencies will say is that the reimbursement rates they receive are too small, which means they can't offer enough services to consumers, and they definitely cannot improve jobs for workers. So all of this is under the rubric, the umbrella of inadequate public funding and reimbursement. Central to this issue of diverse elders is the reality that we are living in a time where we see persistent disparities among consumers and also among workers that are often tied to racial inequalities, racial and ethnic inequalities, but also gendered inequalities, immigration status, and so on. Too often the solutions that people create in the field are universal in nature, meaning that they assume that they will work equally for everyone. And what we know is that that's never the case, right? The one-size-fits-all solution rarely works across people of color, across LGBT people and women and so on. There are also limited what we would call race-explicit workforce solutions that would work with different communities of color, and more broadly, a lack of cultural and linguistic competence for both consumers and workers. So if you're, say, a Mexican American living in a nursing home where no one speaks Spanish, the likelihood that you'll receive the level of support you need without this competence is just is minimized. And so how do we think about that? So the final piece, the final 10 minutes or so of my presentation is really looking at a way forward. How do we think about the kinds of recommendations and solutions that this field needs? Just to frame this discussion, I want to point out 4 general points that really shape how the long-term care industry is thinking about kind of the future of the sector. The first trend is recognizing that we are in a time of growing and changing demographics. I mentioned this earlier, where we're seeing larger numbers of older adults, people are living longer, we're seeing an increase in people with disabilities across the board. We're also seeing a growing diversity in racial and ethnic diversity, and more people are living as out LGBT people. Immigrants are also becoming a growing proportion of the fabric of our country. And all of those have implications for how we deliver long-term care. It isn't just diversity, it's also inequality. And so, as I mentioned before, this also leads to profound inequalities. For those people, it means that they live shorter lives and they live worse lives. And for all of us, it means that the system is increasingly strained, because if we don't pay up front, we ultimately pay at some point, right? The second trend is that the future of healthcare is increasingly team-based and interdisciplinary. Team-based meaning that we're no longer seeing this idea that any of us is only interacting with one doctor who dictates all of the supports that we need, right? If any of us, for example, I go to my doctor, then my primary doctor, I also have a cardiologist, I also have a wide range of specialists who support me. And as I become older, I would have social workers and other people in that system. I have friends, I have family members, I would have a spouse, all of that. And the more we think about the ways in which that entire constellation of supports is supporting our healthcare, the more we can think about how we should be structuring the system. Finally, recognizing that we're not all just people who need medications or treatments or surgeries. We have non-medical needs as well, and broader aspirations. So how do we think about supporting people in a way that goes beyond just a medication or an intervention or a surgery, right? Finally, all of us are part of complex systems and larger communities. And this is especially true about immigrants. So we recently did research on immigrant home care workers. And a question I often got from reporters and from people in public policy was, how do you support immigrants working in direct care? And this is the primary answer. You support immigrants who are home care workers by supporting their needs as immigrants, because they are part of complex systems. Maybe it means we support them as they navigate the immigration system, which has quite a few walls and boundaries. Maybe we support them culturally, because we're living in a country that is becoming increasingly punitive of immigrants and increasingly xenophobic, right? And so all of us are part of complex systems and larger communities that we should be thinking about. In April, a colleague and I in the field wrote an article called "The Case for Racial Equity in Aging Has Never Been Stronger," where we offered a variety of recommendations to support older people of color and direct care workers. And that citation is in the source right there on the slide. But we made a number of recommendations for both aging services leaders and also policymakers, and I'm going to cover them briefly. One is the importance of really making sure that we're collecting disparity data across race and ethnicity, and that we're reporting that data to all the right people at all the right time. So for COVID-19, what this would mean is that, from hospitals to aging service providers to nursing homes and many others, that we're collecting data on cases and deaths of people of color of COVID-19, ideally as often as possible. Maybe it's by the day, maybe it's by the week, certainly not longer than that, although by the month would be helpful. But the more we collect data, disparity data by race and ethnicity in all of those settings, the more we can know if people are the kinds of realities that people are facing, but also if interventions are needed in a certain way. We also often need to survey consumers, all of us, and workers to understand if they are having unequal access to services. Are we receiving the same level of support from the people that are supposed to support us? And the more that we issue those kinds of surveys, the more information we have. There is a wide range of support out there on how to implement what is called a racial equity lens. We have some suggestions in terms of workers, but a number of leaders in the field have developed concrete advice about how do you implement it in a step-by-step way, in a systemic way. And so thinking about how do we implement that lens in the services we deliver, in our workforce development interventions, and also across public policy and government. There's quite a bit of support in that regard. This whole sector needs more money. I mentioned Medicaid, but there are other ways in which we can boost money for these people and these communities. Also, the direct care workforce needs more money. I think the sector needs more money to increase their wages and also to implement training and advanced roles. There are a number of organizations, typically at the local level, but also at the state and national level, that are rooted in communities of color and led by and for people of color. And so how do we fund those organizations to be able to develop strategies based on how they see them and really kind of advocate for themselves, right? So that they're as bolstered as possible. Also LGBT organizations here. How do we support immigrants who face additional biases and hurdles, right? Community-based organizations that argue for immigrant rights, and also providing paid leave, childcare, transportation, and hazard pay for workers, especially essential workers in this moment who are on the front lines of COVID-19, but often don't have any of those supports. We have a framework for what systemic interventions look like for the direct care workforce. And in general, we would argue for strategies that span 4 areas. The first area is what we would call upskilling. This is the kind of skilling that workers need at all levels just to become more skilled over time in a wide range of kind of skill set areas, competencies, knowledge bases, etc. Career paths, of course, allow workers to see their job as more of a career and advance and make more money, to be blunt. Here we also see entry-level training, supports for supervisors. Many people in this sector become supervisors without any training or without any support. And this is bad for them and it's bad for the people that they supervise. And also a wide range of interventions that would help recruit workers and help retain them. We need more research and more analysis on the direct care work sector. We need more intensive program evaluations of any kind of intervention that is meant to address this workforce. We need more work in terms of changing minds in public education. How do we raise awareness among the public at large or among key audiences like people in government or employers, for example, about all of these issues? And how do we build support for policy improvements, right? And then finally, systemically, we need to change the law, the regulations, the public policies that govern this workforce at the federal level and at the state and local level. And there's a wide range of suggestions. Specifically, if we want to improve compensations, we really just need to increase wages for direct care workers and fund the system so they have the money to increase wages. And we've seen this in a few states where they've set wage floors for direct care workers that incentivize workers, of course, to enter and stay in the sector, but also it helps them make ends meet and it helps them avoid poverty. Oftentimes, low-wage workers are also accessing public benefits, and there's this strange phenomenon that the more hours you work, if you're a low-wage worker, the more that your public benefit assistance drops, right? And there becomes a point, it's called a benefit plateau or a benefit cliff, where a worker will no longer work more hours because what they would make more in income surpasses what they would lose in public benefit assistance. That was very wonkish. So I hope people understand that, which is that we need to make sure that, you know, workers are not kind of working fewer hours because they're afraid that they're going to lose that money in public benefits. We need to figure out how to redesign that system, right? And then also, how do we offer financial literacy and counseling programs so that workers can plan for the present, but also their future, in addition to making more money. We need better training across workers. We feel like it should, across occupations and across states. So when COVID-19 hit, if a certain state didn't have enough workers, what we often saw was for doctors would fly in from other states, right? So from New York, there was a great photo of doctors flying in from Colorado and saying, you know, we're going to support people in hospitals. And that was fantastic. It shows solidarity across state lines, right? Unfortunately, that's not possible in the direct care sector. The reason is that requirements vary by state. And if you're a home care worker working in California and you want to fly all the way to New York to support people, you would have to become trained and certified in New York State to work, right? And so how do we better standardize training across occupations and also across states so that it becomes more portable and we can kind of build a sector around the country? How do we strengthen the quality of training programs so that they are adult learner centered and culturally competent? How do we support and evaluate e-learning models? These are virtual training approaches where you might learn to become a home care worker or learn how to, COVID-19 specific protocols on your computer or on your phone. How do we evaluate them to make sure it's effective? And how do we implement advanced roles in ways that help them kind of promote what we call care integration or care coordination, so that they're coordinating care across doctors and nurses and social workers, and really being that bridge across all those people. To promote recruitment and retention, states can commission studies to better understand what kinds of challenges they're seeing in their states and in their cities and towns. Many states are considering a recruitment and retention innovation fund where they would kind of develop a pot of money where people could apply for that money and develop their own efforts on recruiting and retaining. And then in New York City, we have a citywide paid care division, a direct care advocate whose sole responsibility is to advocate for these workers and make sure that they understand their rights, their protections, and that they're properly trained and supported, right? And so we advocate that all states should have a state level direct care advocate who can really be a czar, like an advocate for the sector and make sure they understand their benefits. We need more data, and this starts by states creating the infrastructure to collect more data on the workforce, looking at issues like turnover or vacancy rates or just how many part-time and full-time workers, centralizing who's been trained in some kind of database so that workers aren't forced to be retrained just because they moved from one job to the next within their own state, right? And how do we fund original studies on the direct care workforce? One area that is severely understudied is the gray market, where consumers are paying for and hiring their own workers off the books, making their own pay arrangements and kind of just facilitating that way. We have no data, no analysis in a formal way on this sector. And I think that's one area that could be better studied. And then one exciting and promising trend is that many states have commissioned work groups, coalitions of workforce, aging, and consumer advocates to come together to sort through differences and to develop blueprints and plans on how to improve this workforce, right? It helps them address rural and state issues, the current and future needs, and also look both at policy needs, but also industry practice. And we did research recently to look at what are these coalitions prioritizing, and the 5 top areas that these state level work groups have prioritized are compensation, training, public education, career advancement, and data collection. So all areas that I've been covering in this presentation. So if your state doesn't have one of these work groups or a plan, this is a great way in which we can advocate for all of this work. I've covered quite a bit of content, and I think I'm at my 45-minute mark, so to speak. All of this information that I just mentioned and more is available on our website at phinational.org. We also have a state-by-state data center where you, depending on what state you live in, you can search for data on this workforce by states. We also maintain what we call the National Direct Care Workforce Resource Center. This is the largest online library of resources on this workforce. Most of them are published from 2010 to the present, but it includes reports, journal articles, videos, and whatnot across a range of topics that you can search for. And then finally, we have launched this year a direct care worker story project, where we interviewed workers to tell their own stories in their own voices. So hearing from workers, what are your realities? What are your needs? Or how would you change the sector, right? We have a growing collection of workers there from around the country, worker stories. So please visit our website for all of this information. Also follow us on social media. We're on Facebook, Twitter, and LinkedIn at PHI National, or just search for us by name and I'm sure you'll find us. Again, thank you so much for including me in today's conversation. Thank you for prioritizing this really important topic. And I look forward to your questions and your reactions to the conversation that follows. Thank you.
Thank you very much, Robert. You gave us a lot of information. So now let's take some questions from the audience. Um, I will begin with a question on how do you see the role of higher educations? Like our institution is a Hispanic serving university, and we are a very important port for migration, of all sort of migration, immigration, I would say. We are, right on the border with Mexico. And 40% of illegal immigrants enter through this valley, and many of women become home care workers, and in quite mixed roles, domestic cleaning and caring all in the same package. So we really are very interested in supporting aging and other type of uh, situations in which healthcare at home is needed. And we really want to make use of our multi-professional vision as a university. So how do you see the role of higher education institutions?
Yeah, it's a great question, Gladys. Universities and higher education institutions have always been a big part of major social and political movements. And I'll point out a few points. One is that we work and have worked with a number of professors and departments and universities around the country to better study this workforce or to help advise data collection on this workforce. So for example, we are working in Florida with a university to look at, what are some recommendations that we would offer about how family caregivers should be interacting with home care workers. And they're doing all of the research, all of the data collection, and helping us frame recommendations in that regard, right? We've also worked with professors to map the workforce in certain states. So the University of Michigan, the University of California in San Francisco, kind of giving us a better sense of who these workers are, what are the challenges they face, and what are some of the realities that they're seeing in their specific states and communities. So you mentioned kind of the realities of the border and kind of undocumented immigrants and so on. Like that's a topic that we would love to learn more about. And universities then are able to apply for funding, say from state or federal sources, right? And we work with them to help do the analysis. And then when the story is published, we promote it, right? So we have a number of examples over the years where we've worked on that research. The other part is that, a lot of universities kind of play a think tank role, which is that they do research, but they also do it in an applied research way where they're interested in not just kind of creating knowledge for knowledge's sake. They're interested in connecting it to the government dialogue and really sharing their findings with public policy, with news outlets and all of that. So if your university has a think tank that already does that, that's one way in which you can really shape the political debate. I'll also say that in many states around the country, I mentioned the coalitions that are developing kind of statewide plans and blueprints. Researchers and academics and students are often a part of those coalitions, right? And they help bring that really important academic analysis and thought leadership to their ideas. And so how do we think about kind of connecting as individuals to those coalitions and really bolstering that? And the final thing I'll say, it's less about academics or universities, and it's more about the point you made around undocumented immigrants and home care workers, which is that 2 years ago, we worked with an organization in New Mexico called Encuentro. I believe they are in Albuquerque, though I could be wrong, it's been 2 years. And they are an organization that for the most part, provides immigrant supports to immigrants who, like what you mentioned, are, people who have crossed the border, people who are new to the country, et cetera, and who are still navigating the immigration system, right? And what they did is they actually created a home care worker training program that's specific to Spanish-speaking immigrants in New Mexico. And what they do is, if you enroll in the program, you have to complete a certain number of hours. to become a home care worker. It's all state certified, right? They also help you along the way with immigrant related questions and with immigrant supports. And at the end of the program, you're certified. And they connect you, at least informally with employers in the state who need those workers, right? So it's a pathway from immigration to like home care stability.
I think
Interesting.
that's a wonderful example because we are very interested in promotoras.
Mhm.
And we have among our Institute of Neuroscience promotoras, trainers certified by the state. And
Mhm.
we are actually thinking on how to expand this to offer, red promotoras first, but also other type of, care, home care professionals. Could you comment also on anything that you know about studies on brain health, mental health, addictions? Um, this we get that a lot of home care workers, because of all the things that you mentioned, I guess they, might have some issues that probably needs to be uh, addressed in a more deeper way.
Sure, sure. So I'm not aware of research on brain health and the direct care workforce. There is there is a growing body of research on brain health and people of color and a lot of disparities in that regard, right? So I'm not aware of, incidence rates or anything like that among direct care workers, but that's a great example of another topic that needs to be studied. Um, I haven't seen anything on addiction either. That's interesting. I would love to hear more about, what might be some of the rationale for that. But, I'm a big fan of just broadening it in general. I do think, health disparities. So, when you think about the composition of this workforce being primarily people of color, women, and immigrants, you can imagine that there's probably a lot of health disparities there, right? And because everything from hypertension, um, to heart disease, to diabetes, to mental health issues, and so on. And mental health in particular, one of the things that we see with direct care workers is that, these are very emotional jobs. And when a client passes away, for a home care worker and a nursing assistant, the sector doesn't really offer them grief support or bereavement support. So many home care workers are losing clients that they're actually very connected to and see as family, but they're grieving without any support, without any time off or anything like that, right? That must have a severe mental health impact, right? And it's not really well studied, and it's not an area that many employers support in because they feel like it falls kind of lower in the chain of what the worker might need, right? So I would love to see more research on the impact, as one example, on the impact of client death on nursing assistants or home care workers and their mental health. Um, and it's a disparity that, as we know, it starts in their 30s, 40s. It probably starts earlier than that, but it really starts in their 30s and 40s, and it continues into their 70s or 80s. So how do we think about it across the lifespan?
Yes, thank you. I have a question. I would like, thank you very much. That's a wonderful, presentation.
Thank you.
And that's such an important area. Really, I always kind of wondering about the impact of the healthcare worker, how to measure their impact and if there are studies about kind of looking at the true impact of those interventions.
Mm-hmm.
Uh,
Yeah. So what is the impact of the home care, the healthcare worker on their
right,
clients? Or yeah.
right. About that, and
Yeah.
and maybe a broader question is also what's the kind of impact of even universities' interventions on the general problem of intersecting between poverty, healthcare disparities, and minority as well.
Yeah. Yeah. It's a good question. On the second question, my my experience has been that most of the data and analysis that we have, the evidence base, so to speak, on racial disparities in aging, that it comes from universities, right? I mean, it's where we're getting all of the evidence base, the data, the analysis. I mean, universities and academics have really been the one that made that case. It's not so much nonprofits or governments, or definitely not the private sector. So I think that's a huge impact that universities have on making the case and on studying people who have long been understudied, right? In terms of the impact that direct care workers have, I think when we think about impact these workers are having, I mean, there's a few things. One is the impact they have on their clients, and there's been a lot of, it's enormous. I mean, clients are able to survive because of their home care workers and their nursing assistants. And for clients who don't have family members, who are isolated in their homes or in certain parts of the state, it might be their only communication is their home care worker, right? And so the impact is great. I mean, workers are keeping people alive. But they also, these workers also have an impact on, I would say, cost savings. And that's something that I think employers and people in government are more worried about these days. They want to know to what extent, can a home care worker help us save money? Like, how do we, and that's, I think, where there's been some early evaluation that shows you that a home care worker, for example, who's been better trained, they're more likely to reduce a preventable hospitalization, and that saves money, or an ER visit, right? A lot of people, they feel pain and they call 911 and they go to the hospital, when they didn't need to, really. They just needed somebody to check their blood pressure or do something else, right? And every time they go to the hospital, that costs money, right? And so a home care worker who's been better trained can help reduce cost savings in the long term. And I think the more that we can evaluate those kinds of interventions, like training, advanced roles, et cetera, on money, I think you'll see more, people in government saying, all right, let's invest in this workforce. Yeah.
Thank you. Do we have any other comment or question? I'm wondering from our partners from outside the School of Medicine. We've been working on developing a care model, wrap up model, like the one for kids, where social care and healthcare basically are seen as part of the entry point for a person, particularly in this area of the country where we have about 60% of people that are uninsured. And that's, and many people are really eligible for social support, but they don't know how to navigate that. And so we really, and when we talk about people with brain disorders and aging and elder, we think that it's necessary, the link, that it cannot be healthcare on one side and social care. And I'm wondering if these home care workers could also receive training on navigation of this. So we are trying to design programs basically for the promotoras, but using the promotoras also to reach home care workers. I think that would be one way in which we can get to the people where they are, and try to develop programs that can be really empowering in terms of for their own health, particularly brain health of the home care workers, and also that so that they can lead the person that receives their service to a better or more diverse path. Because what we see is just really, series of tasks that they have to perform, and not really envisioning the real role that they are playing in that home.
Mm-hmm. Yeah, it's a great question. Can I ask the promotoras, who funds the promotoras? Who hires them? Yeah.
So the promotoras are community health workers, and they are mostly different programs sustain them. They have the Association of Promotoras in South Texas, for example. The association has more than 700 promotoras, maybe 900 promotoras. We're here in the Valley, we have about 400 promotoras.
Okay.
And they work with different organizations, different clinics. Some of them work with us at the university. We have one promotora and promotora trainer with us, Dr. Noe Garza, and through our projects, they help us to reach the community. And particularly, of course, we want recruitment for clinical trials and all that, but we also want to help. We also want to increase the social capital of our communities and through health. So we have so the problem is also funding and of course sustainability of programs for funding. That's why we are thinking that perhaps establishing a center or training programs that might be one way in which we could sustain the training to the promotoras and through the promotoras to get to the home care workers.
Yeah, it's a great question. I'd love to learn more about it after this presentation. But I think, some of the things that it brings up for me, you asked sort of how can we bridge the healthcare world with the social support world, right? And I think one of the I think in that example, it seems like one possibility might be for whoever is the entity that kind of employs and manages and hires las promotoras, right? For them to partner with home care agencies in the area, and to talk to those executives and their social workers and all of them to see if there's a kind of a formal partnership that can be developed, so that home care workers, can think about what role a promotora might have in their client's health, right? I think one of the challenges, the other suggestion I have is, depending on where they get their money from, if it's at the state level, requiring that funding for promotoras to work with home care agencies, and also requiring home care agencies who get state funding to work with promotoras, right? There's a way to require it, I think, at the state level. But in general, I think from a higher level, I think that we live in a country still, unfortunately, that's very siloed with our healthcare and with our social supports, right? So I talked to my doctor, who's a private physician in one office, and he is completely disconnected from my cardiologist, who's in another office, and she's completely disconnected from my dentist and my dentist. If I had other workers, would be disconnected from my social support worker or from anybody on the field, right? And there's no net, there's no thread that's connecting everybody, that's connecting data, that's making sure somebody doesn't prescribe something that interferes with something else. And that what I said earlier in my presentation, that understands the interdisciplinary care team and how they should all interact. And in the ideal, a home care worker is probably best positioned to do that. So if that home care worker is supporting a client, that home care worker would ask, who are your supports? And the client would say, my doctor, my cardiologist, my promotora, my sister, my friend. And the home care worker would navigate that communication, right? And then that person would get the best care possible. We don't live unfortunately in a system that has gotten there, but the more that we can push for solutions that do that, the better. And we advocate for that, but we're far away from the
Yeah, hopefully, we are with the leadership of Dr. Salum, we are having a new building institute for neuroscience, and there's going to be a very important clinical component, but it's a research institute, and we want to contribute to the nation with these issues, particularly in favor of Hispanics, individuals that really the health disparities and now have been augmented with COVID. So thank you very much, Robert. I don't know if there is any other comment or question.
No, I mean, just if we have like a couple of minutes, I mean, how much emphasis has been placed on like self-care, using the promotoros or whatever mean, to help people to care for themselves more than,
Mhm.
I mean, I'm
Yeah,
not sure how developed the self-care kind of ideas is within the
yeah.
healthcare system as a whole.
For sure. I mean, I think it's a good question. I think, for our workforce, by the time you need a home care worker or a nursing assistant, it's because self-care isn't enough, right? So you need help with bathing, you need help with eating, you need help with, getting to the doctor. So by the time you get, and if you're in a nursing home, you need that help 24 hours, right? And so it's really about physical and emotional assistance, right? That said, I do think you're hitting on something important, which is even within that, I think training can get better with promoting more self-agency and being able to say, all right, you're helping me with this, but this is an area where I'm okay and I can do this for myself, right? And the disability rights world really argues for that. They say, we deserve to be employed. Just because you're helping me to take a shower doesn't mean I can't do a job, right? So can you help me think about what I can do for myself and then support me, and then in other places support me in other ways, right? So I do hear the self-agency, but I think in direct care it's less about self-care. In healthcare I think it might be.
So it's a very, very complex issues, and we've been talking tangentially using one framework called ACT, um, acceptance and compassion training. And we have in the call, I think we have Dr. Sokolowski, that it's one of our experts on this. And we will follow up. We want to develop different ways to approach this from a very I would say we want radical solutions in the sense that we want to leverage evidence, but we really want to see changes, uh, using robust science, but we really want to use what has been successful in one field to bring it to the area.
Yeah, absolutely. I'm happy to keep brainstorming for sure.
Dr. Miner?
I, yes, I wondered to what extent financial issues in the sense of planning, etc., are important to this, not so much, well, also to the healthcare workers. For example, there's a whole infrastructure of accountants and tax advisors, retirement planners for the community which doesn't have aging issues, but I was wondering if there is a need also for a financial, some kind of plan, the healthcare workers as well as the.
Yeah, it's a huge need. It's a big question. Many states and cities have financial literacy programs for low-income workers. For with opening a checking account or developing a retirement plan or any kind of question, buying a house, like all of that. In theory, those programs should be able to guide you through all of that and help explain concepts. And what we know more broadly is that low-wage workers often don't have the same access to financial advisors or fiscal, right? And they don't have the same level of literacy. So they can be really enormously supportive, right? What we know is that a lot of those programs are under-resourced as well. People will talk about how there are long waiting lines. The quality of those programs aren't always as strong as they should be. We've partnered, at least in New York City, with those programs to develop kind of specific programs for home care workers. So you will say, can you help, our home care workers understand, file their income taxes every year and qualify for the earned income tax credit if they qualify, or plan for their future, fill out all those things that you mentioned, right? And that's been really beneficial. I mean, those workers will say it's amazing. I will say that even with all of that financial support, most workers will say, at the end of the day, I make $10 to $12 an hour, and there's only so much that can be shared around, right? So it's difficult to even allocate a small percentage of that for retirement when, you know, I have rent to pay and food and children and all of that, right? But I do think fiscal literacy is a huge issue for them. And a lot of it, you know, a lot of those resources are not bilingual. They require you to travel. They're often during work hours, so you have to take time off, you know, to be able to access it. I mean, there's all these other barriers that then make it more. But as a whole, we do need those programs.
Well, thank you very much, Robert. We overextended the period for questions, and we are happy, very happy to, you know, to have initiated this conversation, and you know, keep us in mind when you see an opportunity that we might, you know, we might contribute. Please, and keep up with such a great work that you guys are doing, and we certainly will visit.
And thank you everybody for attending, and I look forward to being in touch. Yeah.
Thank you so much.